coming to you from central London to chat about SMILE. Small incision lenticule extraction. Now, I split this up into 4 sections, and I want to walk you through some of the general stuff about the procedure, and then some of the science and research around it. And then we'll hop in and we'll talk about the actual surgical procedure itself, so you have a good understanding of that. Some post-op information and some tips and pointers, and then a little bit of general discussion along the way. So before we get into SMILE, I want to talk about corneal refractive surgery as a whole. As you know, LASIK and PRK, they've been around forever, so we can't just all of a sudden push those off to the side. I mean, look, you see here, there's more than 50 million procedures that have been done. Now we have SMILE. While SMILE is newer to the US, it's not a new procedure by any means. There are already more than 2 million procedures done worldwide, more than 2,000 surgeons doing it. There's a surgeon in China who's already hit his 70,000th SMILE procedure. It's crazy the numbers they're doing in Asia. But there are a few points that I really want to hit home on this slide. One is that they have the same final results, and that's the same between LASIK, PRK, and SMILE. There's the same safety, and finally, SMILE fits in because it gives surgeons and patients another alternative. The best way to think about this for me is like this. LASIK and SMILE, they're fantastic procedures. I love them both. PRK, you don't do that much. You do 1 case a week or 1 case a month, and PRK is probably the best option for you as a surgeon because it's the easiest. All you have to do is put your foot down on the gas pedal and go. So PRK is more like, an example would be my friend Eliza from optometry school. She drove a van, and really none of us wanted to be seen in the van, but guess who was the first one to get a call when we needed to move some furniture? So this is how we look at PRK. I think you get what I'm trying to say. The final point for this slide is that you must, especially if you're a co-managing OD who's not making the decision for surgery for a patient, you must discuss these procedures all on the same level. And you have to do that for a couple of reasons. One is that you probably aren't going to know by doing a quick screening in the office which one is the safest for the patient. Number 2 is something might happen during surgery where the patient came in for SMILE, but has to be switched to LASIK or PRK in the middle of the procedure because that's deemed safer for the patient. And number 3 is if they need a retreatment after LASIK or SMILE, they might need to have PRK. You don't want to say, oh, LASIK or SMILE is the best, and then they end up with something else. It's just not great for anyone involved. Another point I just really quickly wanted to make was that this is not a SMILE versus LASIK talk. I like SMILE, I like LASIK. I don't have a favorite one over the other. They are both great procedures, and that should be one of your takeaways from today. So let's move into the VisuMax Femtosecond laser, so the laser behind it all. So what's so special about this laser? For starters is the flap thickness, and reproducibility in laser eye surgery is extremely important. So when we talk about standard deviation of 4.4 microns, that means if your surgeon is planning a 100 micron flap, because that's what the patient needs to save tissue, or a 90 micron flap, that flap is going to end up pretty darn close to that 90 microns or 100 microns every time you do it. And that is really important in corneal surgery. The second is improved patient comfort. And this is so important for a patient because a patient demands and expects this experience when they go for laser eye surgery. And so to demonstrate this, I went under the laser for you guys. So here I am with a slit lamp photo immediately afterwards. And I did this so you didn't think I was lying. So these here are the suction ports on my limbus, just at the edge of the cornea. Why would I do this? Well, if you work in a LASIK practice or you've co-managed enough patients, I can tell you what the #1 thing they say of the whole procedure was. The suction on the eye was much different than they expected. Let's explain why. Well, these graphs demonstrate that very nicely. So if you look at these graphs, these were published in the JRS, you can understand why it's not a nice feeling for patients. So here, the intralace, the pressure goes up to 150, Femtech over 200, the LDV above 150. But if you look at the VisuMax, it only goes up to about 60 millimeters of mercury at its highest. So to me, when I was having it done, it felt like someone doing applanation tonometry on me for a couple of seconds, and that's it. There's no way I would go under the laser and have my eyes sucked on for you guys with any other device. From a patient comfort standpoint, blows any other laser away. Okay, so let's get into the specifics of Smile. The first thing to get out of the way is the treatment range. Here it is, memorize it. It covers 80 or 90% of the population. Just as a quick aside, the clinic that I do research with outside the US, we're running a couple of trials. So one is a single site, we're the only site in the world doing it, which is Smile between 10 and 14 diopters of myopia. And then we're involved with Zeiss's multinational trial for hyperopia. So watch that space in the future. Okay, so now we can get a bit more into the nitty-gritty of things. So obviously, the biggest difference with Smile is that there's no flap. So instead of a flap, a stromal lenticule is created. So there are some universal terms that you should be aware of. I'm going to walk you through the process of creating a lenticule. First is the lenticule interface. So this is the refractive cut of the procedure. And that's what's going to ultimately change the patient's vision. Next is the lenticule side cut. You can see those form here. That acts as a step. Next is the cap interface, or the upper interface. So the cap interface is planar to the surface of the cornea, and that completes the lenticule. And then finally, you'll have a small incision. And the small incision is what's going to be used to gain entry, for the surgeon to gain entry and remove that lenticule. Okay, so I think we're good so far. This is a lenticule. Now, when these interfaces are being created, it's all about the bubble pattern, because the bubble pattern determines the ease of surgery, the ease of separation, and the speed of visual recovery afterwards. So how do we make sure that the bubble pattern is as close to perfect as possible? We optimize it. So for example, if you look at this image on the left here, this would be high energy with large spot spacing, so the distance between the spots. If you look at this image, this would be low energy with a very close spot spacing. The idea really is to get a perfect balance between these two things. And one thing that you may have noticed is very early on, if you've had any patients come through that were in the very early group of Smile in the US, you might have noticed that their vision recovery was a little bit slower, so it took a few days or a week to get back to normal. But now the US has a huge range of approved parameters for spot and track distance and laser energy settings. And so this will very quickly take care of this, and these patients see really great in most cases on day one. Just as an aside, it's not like a willy-nilly, let's just try these different parameters back and forth until it works. So this is all done with the surgeon and an application specialist from Zeiss, and they will come in and there's a very specific flow diagram that's followed until the laser is fine-tuned perfectly to start treatment. I'm gonna jump out quickly here. So if you're seeing my screen here, I'm gonna jump out quickly so I can play these in full screen. You know what the bubble pattern looks like. So I just wanna play this now for you. And we're gonna watch how this lenticule is created. So here comes the lenticule interface first. This is the lower interface. Remember, it goes out to in. We have the side cut, the lenticule side cut, and now the cap cut, the upper interface being created to finish. And at the very end, you'll see a small incision being created. Ours is here, but in the US, it's at 90 degrees. Okay? So very quick, the whole process is 20 to 25 seconds for a patient. So that is the general, what is a lenticule? And you can see how this is much different than creating a flap and ablating tissue that you do in laser eye surgery with LASIK. Now, the science itself can be a full 1 or 2 hour lecture talking about corneal biomechanics, corneal nerve plexus and innervation, strength of the cornea. But I want to highlight just 2 really simple facts that I think you'll find a bit interesting. So the first is corneal nerve sensation recovery. So obviously, as you can imagine, the corneal nerves are completely severed when a flap is made in LASIK. So you see this drop down corneal sensation to 0, and then slowly come back up over 12 months, it's back to normal. Now with SMILE, if you look at the literature, SMILE drops by about 50% rather than all the way down to nearly 0. And so that means that it's recovered by about 3 months in most cases, and back to full really at 6 months. And this is another study that we did at the clinic, and it just took that curve out a little bit further. So this really suggests that in SMILE, the nerves are, it's like they're just shocked for a moment, and then they come back. And this makes sense because if you see SMILE patients, and you see a lot of LASIK patients, the SMILE patients, they say their eyes are feeling normal, or they don't feel their eyes anymore, or they're not thinking about their eyes much sooner than the LASIK group. They're both happy in the long run, but the SMILE patients tend to recover a little bit quicker when we're talking specifically about the corneal nerve sensation and things associated with that, maybe dry eye. The second bit is regarding the spherical aberration. Now, I did a literature review about a year ago to see how SMILE affects the corneal spherical aberration. This brought me back to my optics days, and I hated that class. And little did I know that I would end up in refractive surgery and refractive surgery research, and it would all come back to haunt me. But I digress. So what you need to understand is that when patients complain about glare or subjective vision changes after laser eye surgery, in a lot of those cases, it has to do with an increase in spherical aberration. Because when spherical aberration hits a certain point, it becomes toxic to the visual system. Right? So it's okay, and it can actually help increase depth of focus. But once it hits that point, it's going to become a problem for the patients. So when we're looking at this, it's important from both a safety and subjective vision standpoint. So you can see here that the change in diopter with SMILE is really, really small, and that's a great thing for patients. Here's just a couple of different studies that looked at SMILE versus LASIK, and you can see that the SMILE group here, pre to post, there was less of a spherical aberration and higher order aberration induction, and same here. You can see that there were lower aberrations induction in the SMILE group compared to the LASIK group. Okay, so that's it. That's it's enough of the science bit for today. So I want to just now get into the treatment with you. I understand that we're not surgeons, but I think this is really important to understand, and it will make you feel more confident. It made me feel more confident when we're talking to patients, and we can answer the questions when they come up. And some of this is just pretty cool stuff, and you really have to take your hats off to the engineers that designed this amazing device. So let's get into the treatment stuff. So where do we stand so far? Well, over the initial bit of the lenticule creation, we went over that. So the lenticule is created, and it's sitting there, and it's ready to be taken out. That's it for SMILE. But if we look at LASIK and how that compares, okay, so the flap has to be created. You have to go through all of that stuff, and that's only half the procedure. You haven't actually done the corneal reshaping yet. So when you're doing the excimer ablation, not the femtosecond laser cutting the flap, But now you're doing the true excimer ablation. There's lots of stuff to think about, and that can affect the outcome for the patient. So it's an open system. This is a laser coming down to an eye, right, with air in between. So you have to think about environmental conditions in the OR, humidity changes, perfume from the patient, eye tracking. So the eye is not immobilized during treatment like it is with SMILE, so it's moving around. So you have to have these super sophisticated eye tracking devices, and there may be parallax errors involved. The ablation time, so an ablation for a -2 patient might be 10 seconds, and an ablation for a -10 patient might be a minute. So this has issues with tissue drying and laser absorption, gas consumables that needed to run the laser, excimer laser calibration. So if the laser is running hot or cold in the morning, and a patient could be over or under corrected more than expected. And finally is the fluence projection error. So the fluence projection is, if you think about when the beam comes down onto the cornea, it's perpendicular and it's flat at the center of the cornea. But as it goes out, the beam head doesn't move. So it's coming now at an angle. And because it's coming at an angle, that same amount of energy is going to be spread over a greater area. And the cornea is curved. And so not only is it spread over a greater area, but it's not perpendicular to the cornea anymore. So these are all things that go into these really intricate nomograms and calculations and figuring out how to treat these patients. That's really all I wanted to say about that. But it's a complicated process when you have to then go in to do an excimer treatment. Okay, so let's get back to SMILE. So the lenticule is created, it's sitting there and it's ready to take out. So I'm just going to quickly walk you through the steps of how that's taken out. One is you open the small incision. And just a reminder here, you see it in these images that it's at 120 degrees. In the US, it's at 90 degrees, but it's the same process. Number two, you use the Sinski end of the instrument and you pocket the cap. So you're going to open the cap interface first, so you have access to the top layer of the lenticule. You'll then dive down into the lower layer, the lenticule interface. You'll pocket that area, so now you can go down to the lenticule interface. Okay? So we've pocketed both interfaces. Next, the instrument's flipped over, so it's a nice blunt end of the instrument. So you don't want anything sharp here because it will just tear right through the stroma. So it's a nice blunt instrument. And if you follow here with the mouse, you insert always on the cap, so the upper layer first, and you sweep around following number 6, sweep across the cap, number 7, and finish by pulling it back out, number 8. So you've got the cap separated. You're now going to go just out to the edge, not pulling all the way out, and now you're going to dive down into the lower lenticule interface. So same thing. However, when you do it this time, you're going to leave this outer red peripheral band. And you do that because it's going to help you keep the tissue in place until the very end. So you core out the center, and then you punch through just the last 20%, and you start to go around the periphery. You're going to then come, so once you got half of it done, you're going to then go back up. You leave a little triangle of tissue attached here as an anchor point, and you finish off, come back down through here. And then the last step, you go back up, you break that last anchor point, and you pull the lenticule out, and you're finished. That's it. So we've got a video here. Okay, so we saw the bubble pattern earlier. It's the lenticule interface being created. There's the lenticule side cut here. Now the cap interface. And finally, the small incision. Okay, now we're going to go, this is real time. So we're going to pocket the cap interface. You're going to press down and go under, make a small opening to the lenticule or under interface. We're going to do the cap sweep. I'm almost all the way back out, core out the center, do the periphery, leave a triangle, do the bottom half, come back, punch the triangle, and then pull the lenticule to the edge, and bingo, done. And what we always do at the end of the case, and every surgeon should do this, is that you look at the lenticule and make sure that it's come out in one whole piece. That's it. That is 1 minute and 18 seconds. And know what you're going to say here. You're going to say that you don't believe me. So I messaged a laser technician and I said, can you just grab a random day and send me 2 patients? So this wasn't me trying to pick out perfect cases that one of our surgeons has done. That's it. This is him sending me 2 cases. He had no idea what I was going to use them for. Okay, so let's watch the second. All right, so same thing. Got the lenticule interface. You have the side cut. Now the cap interface being created. And finally, the small incision. Again, so now I know you guys know the process, but just to watch another case. Open the cap. Now the lenticule. I'm going to flip the instrument over with the blunt bulb end of the instrument. I'm going to open the cap. Separate the lenticule interface, punch through that last triangle, and finished. So that's it. That's Smile, a 2 or 3 minute procedure. It's that easy. And then, as I mentioned at the end of the case, you look at the lenticule and make sure it's come out in one piece. So if I show you all of this again, I hope you get why surgeons like Smile once they become comfortable with it. It's because you can just create the lenticule and you fish it out. There's none of those other things that you need to take into consideration that you need to for LASIK. And for patients, you understand why they like it too. 3 minute procedure, can barely feel the suction or pressure on the eye. Feels like hardly anything's happening, and you have a small incision and no flap being created. Okay, so the procedure's over, the lenticule's out. How do patients do? So first we can quickly look at the FDA outcomes. So these are for a couple of trial centers that participated in the US. So about 90% of patients seeing 20/20, and all patients were seeing 20/40. And the Smile group is here in the light blue and dark blue, light blue, dark blue. And these other are laser platforms that are used in the US. Now, this is really quite amazing if you think about it, because if this procedure was going to be successful, it had to compete with LASIK outcomes right out of the box. And that's a pretty tall order, because as you know, LASIK is the most researched, the most published on, and the most successful elective surgery in the world. And LASIK patients have amazing outcomes. So Smile had a very, very tall order and really lived up to what was created. It was amazing. Obviously, if the patients are seeing well, then the predictability of the treatment must be pretty good. Here you can see 93% of eyes were within a half diopter target. Refractive surgery in general as a whole is extremely stable. Smile is no different. And most importantly is safety. So no eyes lost 2 or more lines of corrected distance visual acuity at 12 months, which is the benchmark in the industry as a safety measure. So you saw the FDA trial results. I wanted to also show you what happens outside the US, where Smile has been practiced longer. So here's a surgeon, Kishore Pradhan, from Nepal. So Kishore came over to our clinic in London, did a 6-month fellowship, and then went back to Nepal and started doing Smile. We asked him to track his outcomes and publish. So after 2 years, he published his outcomes. Check it out. You have 95% of patients seeing 20/20. So here's Kishore in basically a third world country with the most advanced laser in the world, providing patients with a service that exceeds Dr. Joe Schmo in Beverly Hills. It's amazing. Now, obviously, being a clinic that really prides itself on doing what is right for patients, we at London Vision Clinic obviously had to do a comparison for ourselves. So here's ours. So we had 137 consecutive Smile eyes, and we compared that to a matched group of LASIK eyes, 505 eyes. You can see both Smile and LASIK, identical mid-90s for 2020. Safety, exactly the same between the two. Accuracy, exactly the same. Stability, the same. So, and finally, both procedures maintain preoperative contrast sensitivity. So that's us. If you look in the literature, you'll see it's kind of all over the place. So some say that Smile is better. Some are like our clinic, and they publish their results and they're the same. And some publish results that show LASIK is better in their clinic. Where does that leave us? So it's either our surgeons are equally bad at both procedures. No, it's because they're equally trained at both procedures. And we have fantastic nomograms and we get great outcomes. You saw it, 93, 94% of patients in LASIK and Smile. Okay, so finally we come to post-op. This section is super easy. I'm sure most, if not all of you, have co-managed LASIK or PRK patients in the past. So there's not much to go over, that's going to be mind-blowing or teach you much in this section. So there's just a few bits I'll pick out. Routine follow-up after LASIK and Smile is exactly the same. And this can be different between centers or your office, but it's typically 1 day, 1 month, 3 months, 1 year, with further optional visits if you prefer or the patient needs. It is exactly the same as LASIK, with 2 exceptions. One is there's no flap for you to worry about as the doctor seeing them afterwards, and your patients can go back to normal activities the very next day, rather than having to wait a week or 2 weeks because they've had a flap that needs to settle down and seal down. So this takes a lot of worry off of your shoulders as a co-managing doctor, and it takes a lot of stress off of the patients, that they're going to bump or rub their eye and this crazy flap is going to become dislocated. Smile is different. So if you have these, like you see in this picture, if like you or your patients are these kind of people that like to hurt themselves and they're into the pain and you do CrossFit, then just go for it all out the next day. Post-op management, just a couple of things I want to touch on in this list. One is epithelial defects. So Smile is all done through a really small incision. So what that means is that the instrument or surgical manipulation of the instrument is all done through that small incision. And so that can sometimes put some stress on the epithelium right around that small incision. So it could become like roughed up a little bit. Now, if it is roughed up a bit too much, as you can see in this first picture, then it becomes a little bit irregular. If it's roughed up even a bit more, then you can get a little defect in that area. And if it's really roughed up and the surgeon was struggling to get the lenticule out and took a little bit longer, then you could end up with a bit larger of a defect. In any case, you can put a bandage contact lens on these patients. In our practice, we reviewed the last 4,000 eyes that we've done, Smile eyes that we've done, and our surgeons put in 497 bandage contact lenses, so just over 10%. That may be much different than other centers. Our surgeons have a pretty low threshold, so if they see just a little bit of roughness around the edge there, then they'll put on a bandage contact lens, and it doesn't matter. In most cases, you just take it out the next day. It just makes the patient feel a little bit more comfortable. The second is DLK. So you guys all have learned about DLK after Smile. Extremely rare, 0.5% of patients. So we've looked at DLK in our Smile or after LASIK, but we've looked at it in our Smile population. So it's about the same. So in our last 4,000 cases, we had 18 patients that developed DLK, so 0.45%. About 2/3 of them presented as classical, this Sands of Sahara textbook DLK, but a third of them presented with a unique change that we hadn't seen after LASIK before. We published 2 papers on this. And so what happens in SMILE, and this is something you can watch out for as a co-managing doctor, especially, happens at day 1. So if you're seeing a patient at the 24-hour visit, this is one thing that you would want to pay attention to. If you see them at the 1-week visit and they don't have DLK, they're not going to develop DLK. So in SMILE, you can get these focal areas, and this can be a bit scary because focal areas of inflammation, that's could be an infection. That's not a great thing for anybody, especially after laser eye surgery. But we did a case review. We found that these little focal areas, which I think you can see here. So you got a couple of here, one here, one here. This patient had a pretty good bout, so one here and here. These ended up as sterile, non-infectious infiltrates. You can read, there's 2 papers we did. One was a really long case report outlining everything, and then the second was a case series where we created this new grading diagram. But anyways, you can read about those if you want, but just something kind of unique to the SMILE population. And then the last bit is interface haze. Again, I mentioned this, you shouldn't see it quite as often anymore with the new energy settings, but occasionally you'll see, you can just barely tell a difference here in the top row, which is SMILE, versus the bottom row, which is LASIK. So you can see there's just a little bit of faint general haze on retroillumination here. And that's not uncommon really at the 24-hour visit, again, especially with the older energy settings. Now, again, not something you'll see all the time, but if it pops up, it's nothing to worry about. You don't need to change their drops. It fades away in a couple of days or a week, and they're back to normal. So that was where my talk was going to end as of 2 days ago. But then I received an email from a friend who was attending a CE seminar put on by a LASIK chain that had a branch around where he practiced in the US. He had a couple of questions, and I thought they were really relevant, so I popped in some slides at the end. And this brings me to one of my points that I'm most passionate about. You guys and girls are the experts when it comes to eyes, right? And what do I mean by that? I mean that if you have a patient sitting in front of you, that patient thinks that you know more about everything eye related than anybody else in the world at that time point. I was talking to one of our study patients on the phone a couple of days ago, and she asked me, do you see any pediatric patients there? I said, no, and I personally haven't seen a pediatric patient since I graduated optometry school. And she paused, and I thought she was going to leave. And she says, but let me just ask you this question about my daughter's eye problem. And I just had to laugh to myself, because what you say to patients, it carries so much weight and carries so much power that you really need to be careful with the words you use. And I was taught that during residency, and it's something that has stuck with me ever since. I want to put that into the context of refractive surgery. So let's get back to these 2 questions that my friend had emailed me about. And he co-manages some patients, but he doesn't work at a refractive surgery practice. So he did the right thing and talked to someone who knew a little bit more about refractive surgery. That's like me trying to answer a retina question for you guys. The eye for me ends at the back of the cornea or the lens in some cases. So one was on wavefront, one was on eye tracking. And when he was at this CE lecture, the person speaking said that they don't really prefer SMILE because there's no wavefront treatment option and there's no eye tracking available. So just to stress this point one more time, how does your opinion compare to all of these other things that can influence patients to have refractive surgery and who to go and see and what procedure to have? Well, it's easy. It's like yours is way, way off the page and much greater than the next closest. So again, these are the 2 things. Not wavefront guided and no eye tracking is what this person was saying to a group of optometrists sitting there trying to learn about laser eye surgery. Now, The Wavefront Guided is I would love to go over this in detail with you guys about why you don't need to do it and why it doesn't matter, especially in SMILE, but that's like a whole massive argument and hours worth of lecture. But we can try to tackle the other one quickly, because that should only take a minute, which is this: SMILE doesn't provide eye tracking, which some of you might already know the answer to this by just listening today. But let me quickly go through it. So here you can see, let's just go through the steps that we do for eye tracking in SMILE. Step one, we take a reference image. This image was taken on the Atlas topographer, and it's flipped upside down because this is the surgeon view, and we put little crosshairs on it, and this helps highlight where the visual axis is because they're fixating on a target. Step two, the patient's now under the laser on a separate day for surgery. They're looking up at a green fixation target, just like in the topographer, and the cone comes down onto the eye, coming down. Patient's looking at the green target. Keep looking at the green light, keep looking at the green light, and you're sucked onto the cornea. Okay? You engage the vacuum, and then you create the lenticule, which is doing the refractive portion of the procedure. You don't need an eye tracker if the eye isn't moving during the procedure. You need an eye tracker in LASIK because the eye is free and floating around. It is so simple. I'm working from home. So my 4-year-old that I've chained up in the other room could rationalize through this. You don't need an eye tracker if the eye's not moving. That's it. You can't blindly follow without questioning or understanding or doing some investigation yourself, especially when you're referring patients and you're making decisions that's going to affect the patient's life or eyesight. You're just going to have to go play this back, write down everything I said, and then make sure that I'm telling the truth. If you haven't had enough about SMILE, we published the most comprehensive book on SMILE, 450 pages, over 16 hours of really densely narrated video. So this is more than you ever need to know about the procedure if it's really your thing and you've got some extra time on your hands. That brings us to the end, really. So SMILE in 2020, where are we? Well, SMILE is a mature procedure. There have been more than 2 million procedures done worldwide now. More than 450 peer-reviewed publications. The safety and the efficacy are the same as LASIK, which are fantastic. And it's appealing to patients. They love it. They don't have to worry about the flap. They don't have to think about a flap being cut on their eye. They can return to activity, the full activity the next day. So there's a reason that 80% of our practice is SMILE. And there's a reason that for any practice that adds SMILE to their repertoire ends up doing about 80% of their cases with SMILE within 1 year. That's the trend in Europe, and you'll find that that's going to be the trend in the US as well. I'm not saying that SMILE is for everybody. Again, I love SMILE, I love LASIK. I'm just saying that I think that if you want to send your patients to a surgeon for refractive eye surgery, I really truly believe that you need to send them to a surgeon that offers SMILE as well as LASIK, so that the surgeon can then make the choice what is best and safest for that patient. Just so be it that in many cases that's SMILE because it's got those extra added benefits. Thank you, and I hope a few of you picked up a few things along the way, and I'm sorry if you were disappointed that I don't have a proper English accent, even though I lived here for the last 4 years. But thanks again, and cheers from London.